Professor Fatina Fadel, recurrent primary focal segmental venous growth in children.
حضر بس على الجماعة.
مش راضي يديني المحاضرة دلوقتي والله انا هديله خازوق واسع.
بسم الله الرحمن الرحيم.
ما لقيش حد ياخد المحاضرة.
It's my pleasure to be here with you. I would like first to thank all the organizing committee, especially Professor Meher, for this wonderful meeting, and Dr. Amr Singh, dear chairpersons and colleagues. I'm going to speak about the recurrence of FSGS after transplantation. Primary FSGS may rapidly recur in the renal allograft. Some patients have no evidence of primary FSGS in their native kidneys, and FSGS develops after transplantation as de novo. The rate of recurrence is difficult to ascertain because of the heterogeneity of the illness. Recurrence of primary FSGS may occur in cases of primary sporadic FSGS or primary familial FSGS. Post-transplant FSGS may occur de novo, secondary to viral infection or sirolimus treatment. The onset of proteinuria is delayed and more indolent in cases of de novo FSGS compared to recurrence of FSGS. Generally, it occurs 3 months or more after transplantation. Rapidly progressive graft failure occurs in patients with a collapsing form, and de novo FSGS may be a manifestation of chronic reduction, may accompany calcium-urine inhibitor nephrotoxicity, or may be due to hyperfiltration injury. Post-transplant FSGS due to viral infection may be induced by HIV, parvovirus B19, hepatitis C virus, the Steinbar virus, possibly CMV, BK virus, and simian vacuolating protein, which is one of the polyomaviruses, and the viral-induced FSGS usually is of the collapsing form. Here we have collapsing form of FSGS with widening of the Bowman spaces and narrowing of the vascular loops in the sclerotic area. Sirolimus induced, as Professor Ahmed had shown, sirolimus is accompanied with proteinuria, which is usually tubular, but it was reported that it has effect which might result in podocyte dysregulation with decrease in synaptopodine and acquired expression of cytokeratin, which will induce the sclerosis, and it may also result in upregulation of vascular endothelial growth factor. As regards the recurrence, we have recurrence of sporadic primary FSGS, which is more common to occurs in 20 to 50% of cases, especially those cases with high risk factors, including patients less than 20 years of age, rapidly clinical course of the native nephropathy, with interval from the onset of the disease and discovery of FSGS to end stage of less than 3 years, the recurrence in a prior allograft and in African American race. Recurrence in patients with family history of FSGS is reported to be extremely low, and most cases of post-transplant recurrence with Budosine and PHS2 mutations are still responsive to aggressive treatment despite being resistant to therapy pre-transplant. As regards the pathogenesis, we have mutations of genes encoding podocyte proteins, which may result in FSGS, presence of circulating permeability factor, or deficiency of a protective factor, may be drug-induced or viral-induced due to alteration of podocyte membrane proteins. For familial FSGS, there's mutations of many genes. Among these genes, which encodes the podocyte protein, we have the alpha-actinin 4, NPHS2, TRPC6, and CD2AP. Here we have the podocytes and several proteins which are encoded with genes previously mentioned as the nephrin, podocin, and the synaptoprotein and the alpha-actinin 4, and these are encoded by several genes which keep the integrity of the slit diaphragm and the glomerular basement membrane. Second factor is the presence of circulating permeability factor. It was observed that serum from some patients with FSGS increases the permeability of isolated glomeruli to albumin, and recurrence occurred in up to 85% of cases with positive serum compared to 33% of those with negative results. This circulating permeability factor is non-immunoglobulin with a molecular weight of approximately 30 to 50 kilodaltons and mediates through integrin-linked kinase. This circulating factor has high affinity for galactose, so intravenous or oral administration of galactose to a transplant patient with recurrent FSGS markedly decrease serum permeability factor activity. Deficiency of protective factor, in some cases a factor which is not yet defined in normal serum may be lost or absent and results in the increase of the permeability noted in FSGS. The consensus recommendations has historically been that living-related donor transplantation should generally be avoided. However, by the time this has been changed, this may be particularly applicable in patients at high risk for recurrence as young age, as we mentioned before, below 20 years, rapid progression of the primary disease, and recurrence in a prior allograft. The recurrent allograft disease registry found a similar rate of recurrence among adult recipients of living or deceased donor kidney. This for donor selection, which is more preferable to take a living or deceased donor kidney. They found no difference in the rate of recurrence between both. A deceased donor kidney was more likely than living-related kidney to be lost in patients with recurrent disease, so they concluded that in adult recipients, graft survival advantage for living donor kidneys over deceased donor kidneys. In children, the North American Pediatric Renal Transplant Cooperative Study database concluded that in both children and adolescents, the graft survival was markedly worse in pediatric patients with FSGS compared with those with other kidney disease, a difference that was not accounted only for the recurrence of the disease. In FSGS, graft survival at 5 years was not statistically different between living donors and deceased donors. There were some difference. Living is superior than the deceased donor, but the difference was not statistically different of importance. It is recommended to test potential living donors who are siblings to determine whether they carry the suspected podocin gene and PHS2. However, the clinician should be cautious with a donor with heterozygous LPHS2 mutation, as the clinical significance of such a lesion is currently uncertain. And some centers do not use heterozygous donors at all. For the second transplants, patients who develop recurrent disease in the first transplant are at very high risk, up to 70% for recurrence in the subsequent allografts. Graft loss due to recurrent disease is seen in 10 to 80% of the cases, and if the first graft is lost due to recurrent disease, a second transplant should be delayed for 1 to 2 years till the disappearance of the circulating nephrotoxic factors that are responsible for the glomerular injury. How to prevent this? Recurrent glomerulonephritis, including FSGS, tends to be lower in patients who received thymoglobulin, ATG, compared with interleukin-2 receptor antagonists. So if we use induction, it's better to use ATG. Screening for recurrence, this is very important also for prevention. Early detection of recurrence. As Professor Ahmed Gaber had shown that protein excretion from the native kidney decreased significantly in the first 2 months of transplantation. However, about the discussion, if the patient has severe proteinuria, massive proteinuria, it's better to do nephrectomy. Whether this nephrectomy is medical nephrectomy, renal ablation, or surgical nephrectomy. And actually we have several cases among children with nephrotic syndrome which have been transplanted, and we did nephrectomy for them because this will be very, for us it will be a dilemma whether this proteinuria after transplantation is from the native kidney, especially if they are, and we have several patients on regular hemodialysis, primary nephrotic syndrome, and still proteinuria, still edematous, still having ascites, so we usually do nephrectomy. Also to diagnose renal biopsy, whether protocol biopsy or if the proteinuria exceeds 1 gram, is to be done, and PCR for viral screening. Clinical manifestations. Patients with recurrent disease are more likely to have acute renal failure in the first week after transplantation, and more likely to have episodes of acute rejection. And graft loss is most often due to acute rejection rather than the progressive glomerulosclerosis. So early treatment after onset of proteinuria carries more prolonged remissions. First, we have to remove or try to remove the circulating toxins with protein adsorption or plasmapheresis or administration of cyclophosphamide. Plasma exchange for 3 consecutive days, followed by every other day for a total of 9 treatments. Intermittent immunoadsorption combined with B-cell depletion by rituximab treatment induced prolonged reduction of proteinuria in a high-risk patient for recurrence of FSGS in the graft. And this is a comparison between protein adsorption and plasma exchange, and it showed better results with protein adsorption. Intravenous immunoglobulin may also be useful to treat recurrent FSGS instead of plasma exchange. We use intravenous immunoglobulin. Also, it would help in treatment of underlying viral infection. We give 400 milligram per kilogram per day for 5 days with a single repeated dose in 3 weeks. This shows different strategies for treatment of nephropathy, including trial to decrease circulating levels of permeability factors, as we said before, using plasmapheresis or cyclophosphamide. We mentioned before also that galactose has high affinity for this circulating factor, but it can be used, and rituximab. Trial to protect podocyte by stabilizing natural defense or blocking activation by use of ecozonamide to protect the endothelium using serine protease inhibitors, and to protect kidney from fibrosis using anti-TNF and anti-GF factors. About our experience in our reach, we have 78 transplanted cases since May 2009, 69 were living-related donors done in our reach itself, and 8 living unrelated done in Newcastle Laney Teaching Hospital. In 5 of these cases, the original renal disease was FSGS. 4 of them were sporadic, and 1 was familiar with NPHS2 gene positive. For all these 5 patients, we did 9 sessions of plasmapheresis before transplantation, and we give induction ATG as single dose 5 milligram per kilogram. And on-demand graft biopsies, we encountered 2 cases out of 26 done biopsies to have FSGS, but none of them were due to recurrence. The 1-year graft survival, 95%. 4-year graft survival, 88%. And about the FSGS patients, the 1-year graft survival is 100%. We have 4 out of our 4 patients doing well till now. So, take-home message: FSGS is high-risk group for transplantation. It's better to do pre- and post-transplant plasmapheresis for such patients. Use ATG for induction. Living unrelated donor is the best to be taken. And if we are going to take living related donor, it's better to screen for high risk, the patients of high risk group for NPHS2. And we have to start early aggressive treatment for recurrent FSGS, particularly the familiar form. Thank you for it.
ممكن اسال سؤال؟
طب سؤال واحد بس عشان نلحق بقى.
انتوا فاطينا انتوا بتعملوا بري ترانسبلانت بلازما فيريسيس.
أيضا.
هل نقدر يعني ده اللي لما سمعت المحاضره، هل احنا النهارده لو لقينا اذا كان ده فيه permeability فاكتور سيركوليتنج، لو ممكن ناخد نشوف اذا كان هيقلل البروتونوريا قبل الترانسبلانتيشن، يبقى ده لابد اعمل بوست ترانسبلانت. لو لقيته ملوش افكت يبقى ده معناه مفيش permeability فاكتور. لان هو البلازما فيريسيس هي عشان تشيل البرميابيليتي فاكتور، وده مش موجود. احنا قلنا موجود او ديفيشنسي اوف اذر فاكتور. فهل نقدر ناخد جايد من البري ترانسبلانت بلازما فيريسيس ونتائجه عشان نشوف هل ده من انهي نوع، ما دام انا ما عنديش طريقه اقيس هذا البرميابيليتي فاكتور؟
هو حضرتك احنا we have 2 situations. Either the patient had already done nephrectomy, and we have several patients like this. We also do plasmapheresis before transplantation, and we cannot, in such patient, know the extent of proteinuria. No urine at least. إذا ما كانش عامل, we didn't do this, but it is an idea. Yes, of course. To measure the levels of proteinuria before and after plasmapheresis.
أنا مش بقول، أنا بقول أشوف نتيجة البلازما.
هو أصلا هو فعلا الeffect of plasmapheresis هيبقى to remove the permeability factor. بس it is not a must to affect the proteinuria. يعني ممكن ألاقي نفس البروتونوريا موجودة although the permeability factor had been removed by the plasmapheresis. لا لو كده خلاص أنا بقول في 2 situations. العيان anuric عشان أعمل nephrectomy أو on regular dialysis، أو لو في urine هشوف
البروتونوريا ممكن تبقى declining spontaneous مع ال end stage situation.
لا ما أنا عارف، أنا هعمل له، أنا هخبحه 3 أيام، الراجل جاي هيزرع خلاص، هعمل له بري ترانسبلانت بلازما فيريسيس، اقيس البروتونوريا قبليها وبعديها. ممكن انا بقول، انا بس لما لقيت فيه بيعملوا بري ترانسبلانت بس جت في دماغي لو لقيناها لها امباكت وقللت البروتونوريا، دي معناها اندايركت ايفيدنس ان في سيركوليتنج بيريود.
لازم اكمل البرولونج تركيز بعد الترانسبلانتيشن.
فكره يعني لقيتها عن اسمه بس
لو العيان بيجيب بول اصلا يا دكتور.
ايوه، ما انا بتكلم طبعا لو عيان مش عامل افكت وعيان بيجيب بول، انا بتكلم في عيان بيجيب بول وعنده بروتونوريا وعملت له بري ترانسبلانت بلازما فيريسيس، اقيس ده وبعد قبليها وبعديها، اذا لقيناه بيقل معناها بروبابلي كذا. ما هو الكلام ده كله
بس لو هو بيجيب بول
عندنا كمان living related في ال FSGS
لو هنعمل living related حضرتك بنعمل بس جين study to exclude ان هو a carrier of the NPHS trait.
Okay, third presentation.